of an 81-year-old Caucasian gentleman who I've been seeing for several years. And I started seeing him actually because his wife, who is at least a decade younger than him, maybe 15 years younger than him, thought that he was having problems with dementia. He had been diagnosed with depression, and she really felt that there were still memory concerns after his treatment for depression. So the reason I wanted to present him today is, and we talked about this a little bit on our last memory echo, but just to revisit medications for patients with memory loss who are experiencing anxiety or agitation. And as I noted there, I often just try hydroxyzine for anxiety, and then the physician that I work with has encouraged me to use trazodone for agitation or for sleep. And I make sure that there aren't any contraindications medically or with other medications. And then the other interesting point about this particular case is support for caregivers. The wife is also a patient of mine. So the story is that, he was diagnosed in about 2018 with mild cognitive impairment. I started him on Aricept, and he, at that time, I did refer them for a neuropsych evaluation, but I don't think they ever kept that appointment. He started on Aricept, and he sort of stabilized somewhat and is currently on Namzaric, which is Aricept Namenda 2810. He, but at the time of this visit, which was a while ago, I think it was in October, the wife requested a telehealth appointment with me because he was becoming quite anxious in the evenings, and he had pacing and just seemed agitated. He wasn't combative or anything like that. So at that time, I put him on hydroxyzine 25 milligrams 3 times a day as needed. And to be honest with you, I'm not sure that I've had follow-up with him since then, which I take as a good sign. He's a really sweet, pleasant guy who is one of those people who is fairly adept at just, I would say, kind of disguising his memory loss because of his charm. But when you try to get any more detail on history when you're talking to him, he just turns and looks at his wife, and then she answers. So at any rate, let's see, is there anything else? He has not had an MRI that I know of. His comorbidities, you can see there: AFib, hypertension, coronary artery disease, early kidney insufficiency, hyperlipidemia. He has a past history of bladder cancer. I can't remember what year that was, but it's been a long time ago. He gets some care at the VA. He is a vet, and I can't remember the details of his military history, but I have talked to him about it. I think he was in the Navy, actually. His baseline labs when I first started seeing him were normal, and it's been since then that he's had this mild decline in his renal function. Those are his medications. The allopurinol, he must have some gout that I don't have listed, but then amlodipines, talipram, he continues on for the depression. Eliquis, of course, for the AFib. You can keep scrolling there, Mitra. Those other ones are kind of obvious. Pravastatin, and that ranelazine cardiac medication. You must have a touch of COPD too, for that inhaler. I'm not sure how long they've been married. She's about 15 years younger. She has her own health problems, mostly related to chronic pain due to some pretty significant back issues. I don't think it's spinal stenosis, but I think there's disc herniation. And she copes with that pretty well, but you know, that complicates her life. They have adult children. They don't get a whole lot of support, and I'm not really clear on the backstory on that. She, at some point this fall, right around this time when he was fairly agitated, really was struggling with being the caregiver. She doesn't feel that they can afford help to come in with things like cleaning or just giving her a break. So she does it all herself. She struggles with him. For example, she's talked about, I tell him we have an appointment at 10 and I keep reminding him, and I go in and it's 9:45 and he still hasn't put his shoes on. And so she she struggles with, which she knows is not obstinate behavior, but she still has a really hard time, you know, managing to get him to do things. So she and I have talked over these past couple of years. I have referred her to the Alzheimer's Association, although as Teresa and Amy and I were saying in a call recently, I haven't made what I guess you'd call a warm handoff, like giving her a name. I did start her on some antidepressant at a visit, and she was doing better the last time I talked to her. But just that she's not able to leave him alone and do her own things has really been pretty hard for her. So that's the story, and those are my questions about medication for the patient for agitation and depression. And I just thought it's interesting to have a conversation about caregivers.
Thank you so much, Jen. You always do such a wonderful
thank you.
Presenting cases and detail and everything. So we truly appreciate that. Did anyone have, before we jump into any recommendations or feedback, did anyone have any questions for Jennifer in the case? Feel free to unmute or chat in. Any feedback or recommendations? I can pull up the questions again.
Jen?
Oh, Amy, yeah, sure.
Yes. Okay, I was just curious. Is there a documented advanced care plan in place, or have discussions happened between the wife and the husband and yourself around that?
You know, that's a great question, and I think probably not. That would be something to do. Thank you.
Thank you, Amy. Any other questions, thoughts, comments? Hey, Dr. How are you?
I'm sorry.
No worries at all, no worries. Any other, oh, Teresa, I noticed you had unmuted, but it's a little difficult to hear you. Oh, there we go, we can hear you now.
Okay, so I was just going to say, you know, you can always refer the person to me, and if there's any specific questions that I can follow up with, you know, as you know, we have the written resources, and as we talked to, just sometimes giving, you know, someone my particular name, that might help. You know, sometimes that one-on-one, they you know, she might have, you know, maybe more questions or be willing to ask more questions and maybe be more receptive to some guidance.
I agree. I think that may be the key to getting people to realize what's available.
Sure.
And Teresa, I know you had sent over in the past the Alzheimer's Association hotline. So I include that in the recap emails and the reminder emails. So if anyone needs to pass that along, certainly do so. Any other thoughts or comments, questions?
One thing that comes to mind for me is when you talk about kind of agitation and anxiety in the context of cognitive impairment is educating the caregivers, because sometimes there's a misconception of this being the person's being obstinate or whatever else, as opposed to this being kind of a part of the disease process often. So kind of conceptualizing that for the caregiver as part of a dementia process, I think can be helpful.
Thank you.
Sure.
So I was hoping that Dr. Wilhelmsen would be here shortly. I'm texting him, but he had some comments, Jennifer, having just kind of looked at the case a little bit about the medication. And so I'm going to see if we can get him here because I'm hesitant to speak for him.
Sure, that's fine. I know we have a didactic too, so whenever, if he's able to join or send feedback now or through Mitra, that'd be fine.
Okay.
Thank you.
Absolutely. And Jennifer, were there any other questions or thoughts you wanted to share with the group about this case?
Nope, that's good. Thank you.
Awesome. Sounds good. Well, thank you so much again for the case. We always love a good case. All right. So, Dr. Howell, if you get any of those recommendations on the medication, just feel free to shoot me an email and I can send it over to Jennifer as well. Or if you can join the session live, that's always awesome too. Yeah, thank you. Dr. Keith, I can pull up your PowerPoint on my end and I'll just turn things over to you. Just let me know when you want me to go to the next slide.
Okay, so today I'm going to be talking about communication of findings. Can everyone hear me okay?
Yes, that's perfect.
Good. I want to encourage people to jump in with any questions, comments at any time. I like things to be pretty discussion based, so please do not be shy about that. Okay, next slide. So I have nothing to disclose. Next slide. Thank you. So I wanted to give a shout out to this book here before I kind of dive into things. It's called Feedback That Sticks. And while it is kind of centered around communicating neuropsychological test results, I think that a lot of the broad concepts do generalize quite well. So I did use this book heavily in preparing the presentation, and I've used this book heavily throughout my training and kind of learning concepts and delivering test results and communicating with patients. So I wanted to give that shout out since I have used this book a lot in preparing this. Okay, next slide. So why is it important to think about communicating results? So this is a key component of patient-centered care. And as I was typing this, I was like, I wonder how they define patient-centered care. I wanted to remind myself the purest definition of patient-centered care. And the Institute of Medicine says that it's care that is respectful of and responsive to individual patient preferences, needs, and values, and ensuring that patient values guide all clinical decisions. So in order to incorporate patients' needs and values, I feel like that requires you to have some good communication and to ask them really what their needs and values are, and to really allow them to play a more active role in their care. And when they have a better understanding of their health conditions and the treatment options, then that kind of facilitates them playing a more active role in their care, which is generally much more effective than telling people what to do without kind of that understanding. It promotes more buy-in on their part. It makes them care more, and ultimately, no surprises here, leads to better health outcomes and better patient outcomes. Patients tend to be more satisfied too when they have a better understanding and there's more clear communication. And there is some literature, I didn't do a deep dive into this, but there is some literature out there on patient-physician communication in terms of why and how and patient preferences and kind of what's preferred in different settings, primary care, radiology, et cetera, et cetera. So I was glad to see that there are some people studying this because I do think it's very important. And some articles even suggest that it decreases physician burnout as well, clear communication with patients and having them be involved as an active member of their treatment team. So very important. Next slide, please.
So another anecdote in terms of why it's important. So this is a quote from a patient in a study that was examining perceptions, risks, and benefits of treatments for localized prostate cancer. And it says, "You tell me the chance of becoming incontinent from the surgery is 5%. What does that mean? If I get it, it's 100% for me, right?" So I think that assuming patients understand percentiles can be somewhat dangerous in terms of them making decisions about their healthcare. I think that we use this language without thinking and assuming that it generalizes when it often doesn't. So I think that it's important to keep those things in mind. All right, next slide, please. So along those similar lines, we become very accustomed to thinking and speaking in the language of our profession, so much so that our jargon often becomes invisible to us. And I think that a good little study back from 1990 kind of represents this in a way, where they looked at tappers versus listeners. So they divided a group of people into two groups. One group had to tap out the melody to a very common song, something like Happy Birthday. And the listeners had to guess what it was the tappers were tapping, what the song was. And then the tappers had to predict whether listeners could correctly guess these common songs. And it turns out that the tappers predicted that the listeners would be correct 50% of the time, when in reality, only 3 out of 120 songs were correctly guessed. So the tappers grossly overestimated the listener's ability to guess what it was they were tapping. This could be because when you hear it in your head, it's really hard to imagine that the other person isn't picking up what you're putting down. This has been discussed as something called the curse of knowledge in some areas, where once you know something, it's very hard to imagine not knowing that thing. Furthermore, the tappers tend to misattribute the problem as a lack of capacity in the listener, as opposed to them just really not getting the information across. And I think that this misattribution issue is something that's particularly important for us to think about when we're working with cognitively impaired patients, that we're not kind of misattributing our lack of communication as their cognitive impairment. So important to keep in mind, and I thought that was kind of interesting and applies well to what it is we do, really. All right, next slide, please. So as a clinical psychologist, I often tend to think about communicating results with patients similar in the way that I think about psychotherapy. So in psychotherapy, you kind of have two primary components. You have your specific factors, which are your techniques that you use. So things like CBT, ACT, etc. And then you have something called the non-specific factors. And these are things like the GOO, the genuineness, the empathy, the positive regard, things that really create this strong therapeutic relationship, a strong trusting relationship. And this kind of stems from some pretty old research back in the 1930s, something called the dodo bird verdict, where they established that all methods of psychotherapy were pretty equal in effectiveness, likely due to what they consider these non-specific factors that are common to all types of modalities. And while more recent literature may suggest that there are some types of therapy that maybe are more effective than others, I really do think that there's something to these non-specific factors still, and the importance of the therapeutic relationship and having this empathy and this genuineness and this positive regard. So I think that all of these factors are important outside of the therapy context as well, and that you kind of incorporate this therapeutic approach in your communications with patients, whether you're delivering results, seeing them for the first time, or whatever it is that you're doing. All right, next slide, please. I also think it's important to talk about communication of results and feedback beginning from the very first patient contact, which is often at intake or initial consult. Even though at this stage you're not typically giving them feedback or results, I think that this is an important part of laying the foundation for being able to be successful in your delivery of results in your communication. Because it's really at that first patient contact that you begin to establish trust and rapport and kind of initiate all of those non-specific factors that make it important and kind of set the stage. This also allows you the opportunity to enlist patients and family as kind of active collaborators in this relationship, as they are often there as well, and really manage expectations. So when people come in saying, we want to cure mom's memory, kind of setting the stage for what you can and can't do and what to expect moving forward in terms of what's realistic. Another thing I think is important to explore potential defenses and barriers to effective communication. So understanding maybe their preconceptualizations or belief systems. For instance, mom or dad is just lazy, they don't want to do anything, as opposed to apathy being a part of many neurodegenerative processes. So what are some of the barriers and how do they really think about this person and what their symptoms are? Really all helps lay the groundwork in terms of both what you're going to communicate to them and how you're going to communicate with them, keeping in mind what language they bring to the table, what kind of language do they understand and how do they like to frame things and what makes sense to them. So really kind of taking into consideration this whole person approach really lays the foundation for communicating any test results moving forward. Next slide, please. This is another interesting book, which I have not read in its entirety, but they mention it in the initial book that I talked about, Feedback That Sticks, and I thought it was kind of interesting. So this is called Made to Stick, Why Some Ideas Die and Others Survive. And it kind of addresses the idea of why some ideas, like urban myths of kidney thieves and things like that, rapidly spread and persist despite being completely untrue, while other more scientifically sound ideas might kind of fall by the wayside or be hardly noticed. And they kind of developed these 6 core principles in terms of what makes an idea sticky that I thought was just kind of interesting to read about and go over. And they may not all apply to every single situation, but I do think that some of them were interesting and might apply to what it is we do. So I'll just kind of briefly review some of those. The first is simplicity. Which doesn't necessarily mean dumbing something down, but really kind of filtering out, trimming the fat, convey the main message, because sometimes the main message might get lost in all of the convoluted details that might not really make sense or be as important. So really simplifying the message so that it makes sense. Unexpectedness, which I thought was kind of interesting. What they mean by that is really just capturing someone's attention. This can be done potentially with use of things like analogies. Keeping things interesting. Concreteness, I feel like this is one that in neuropsychology at least we're often very guilty of in terms of using all of these abstract concepts that really hold little meaning to most people in the language that we use. So kind of making it more meaningful to people, more concrete. What does this really mean when you're saying this? Credibility, I think, is where the really good trusting relationship comes into play. If they trust you and you have a good relationship, then you'll be seen as a more credible source, and they're more likely to take what you're saying and to really buy into it. Emotions are definitely important. Belief is not enough for people to take action. They have to really care about it. So kind of presenting things in a way that people might care, that they understand and they care. And then stories, which is another one that I thought was interesting, as we don't often as medical providers engage in a lot of storytelling, but I think that it has its place where it could be potentially useful and applicable. So I thought that was interesting. So some principles to make an idea sticky. All right, next slide, please. So I liked something that I read about feedback, framing it as giving people permission in terms of setting the stage for an optimal environment to communicate with patients and deliver results. And it refers to giving people permission or patients permission to do various things, the first being expose vulnerabilities. So people often come into our offices afraid that our results will confirm their greatest fears. And as a result, they might hold back. They might feel vulnerable and hold back questions, hold back thoughts out of this fear of exposing their vulnerability. So having a space where patients feel comfortable in exposing these vulnerabilities, I think is important. Permission to ask questions is also another important one. If patients feel like they have fear of judgment or assume you don't have time, then really important opportunities could be missed there if they don't feel comfortable enough to ask you the questions. Permission to cry. So that's more about kind of feeling heard and safe to be able to express these difficult emotions. Again, kind of preventing them from holding back some important thoughts and questions, and kind of tied into this permission to grieve. Sometimes cases, there are cases where we don't have the best of news, and so giving them that space to grieve and to be heard is often really appreciated. Also, permission for family members to consider their own needs. And I think that that's a really important part of what we do, is including family members and also letting them know that it's okay for them to have their own needs, and really encouraging them to get the support that they might need. Is an important part of this process. And then finally, permission to hope. Even though some of the news we deliver is not ideal, there are always things that we can do or recommendations that we can make to help or improve outcomes and quality of life in every situation. So I think also focusing on that piece is important. All right, next slide, please. I really like the idea of scaffolding language to help patients express their concerns. So patients and family members may or may not have the language to express their concerns. So I often like supplying the language, but without putting words in their mouth. So some people in this circumstance are concerned about this, or that, or many people with this feel this way. Giving them the opportunity to feel that way, but also feel a different way. So not assuming that they do feel that way, but giving them the space and opportunity to express that if they do, and opening the door to conversation if they don't. So allowing them to express those concerns in a way that gives them the language to, if they desire. And then, of course, validating whatever concerns end up being raised, both in the moment after delivering results and also initially. So in my clinic, sometimes people will come in so concerned about their memory, and then their test results look great from a normative standpoint. So making sure that I'm not dismissing their memory concerns, even though their test data might look good, and kind of taking that opportunity to talk about formal testing, which is generally in a very controlled environment, versus the daily experience and what that means, and kind of validating their experience of memory concerns in their day-to-day life, and what might be some reasons for that and how we can help, versus completely writing them off if they don't match up with what my test findings are. So that's another thing that I find to be helpful. All right, next slide, please. Another thing that I think is helpful to consider are various cultural differences. So being sensitive to ethnic and socioeconomic groups. Sometimes we require the use of a translator, and there are a lot of difficulties to consider that come along with that. There are differences in normative data and a lot of limitations there when you're working with diverse groups. And there are differences in terms of norms about involvement and roles of family members, use of certain titles, what the roles are in a particular family, which issues are considered taboo, et cetera, et cetera. So I think kind of having some knowledge of that and being sensitive to that can be important. There are some things that are normative in one culture, but in our dominant Western culture, it could be considered extremely bizarre or even pathological. So kind of having some awareness of that and keeping that in mind can be beneficial. Also talking about differences in SES, and I feel like in West Virginia, you see a pretty wide range here in terms of social economic status. So keeping that aspect in mind in terms of making your recommendations and conveying the results. What does this patient have access to? Do they have access to what you're recommending that they do, both financially and in terms of what's available in their often rural areas? So considering access and issues related to SES can also be beneficial. All right, next slide, please. So I did want to touch on issues specific to communicating with older adults with memory impairment, since this is the Memory Health Echo meeting. So I wanted to talk about some of those issues as well. One thing that often comes up is distinguishing between normal aging and memory loss. You see a lot of patients that come in and say, yeah, my memory is not so good, but you know, it's just age. And sure, aging can be associated with memory loss, but kind of explaining that continuum in terms of what's normal aging versus mild cognitive impairment versus a dementia, and kind of explaining that spectrum in a way that makes sense, I think is often an issue that comes up, as well as addressing alternative explanations for memory loss. One thing I see a lot of is, oh, it's just grief or depression, or this person lost their spouse a handful of years ago, and really it's just that. And while that could certainly affect someone's cognitive abilities, there are situations where it's clear that there's probably something else going on here in addition to that. And so being able to acknowledge that, yes, there could be multiple things going on here, but in addition to the grief, we're concerned about this or that. So kind of addressing those alternative explanations that families often come in with that may or may not be at play. And then reassurance about preserved skills, so things that remain within their control as opposed to focusing on what they can no longer do. Also kind of maintaining hope and optimism, I also think is important. All right, next slide, please. So addressing unawareness is a very challenging aspect in communicating with older adults with memory impairment that comes up so frequently. I thought it would be worth discussing. So there are a lot of different ways to handle this. It's part of the disease process, so I think first contextualizing it as not just being difficult or obstinate, but as kind of a part of the disease process is important, particularly when there are caregivers involved who aren't really sure, oh, they're just in denial, or they just don't want to accept it, when it's really part of the disease process. So like I said, there are a lot of different ways. Sometimes I find it's helpful to refer to the objective test data. Sometimes I've heard people use phrases like, you can't remember what you can't remember, or when you have a problem with your memory, your brain doesn't let you know about it. And sometimes there's really nothing you can say, that this person's not going to agree that they have memory impairment, and there's really no point going back and forth about it. Dr. Kapp, do you have any thoughts in terms of addressing this?
You know, I mean, you said one of my favorite phrases is that, you know, sometimes you can't remember what you don't remember, including that you have a memory problem. Yeah. The other thing that I do talk about is that it's a very normal part of the disease. That when your brain is so complicated that one of the things when you have a disease of the brain that you lose is your ability to see these things. And then I contextualize it that we see this all the time. It's not just you. That's why we're so glad your son, your spouse, whoever is there, we see this all the time. I just saw this 5 minutes ago, and just kind of try to give that context that it's really very common and that we're not surprised by it and we're not upset by it. And sometimes they'll just kind of take a breath and go with it. Yeah. And sometimes not.
Yeah, that's true. Normalizing, I think, is also an important piece. This is part of it, and this is common. We see this every day.
Yeah, and not make a big deal out of it, and just kind of go with it.
Yeah, and I think that that's good modeling too with caregivers, because some caregivers have a tendency to really kind of jump in and correct, and it becomes this kind of power struggle and back and forth argument. But in feedback, if you're kind of modeling that behavior where you're just kind of going with it and not really going back and forth about it, I think that can show caregivers that this doesn't have to be a big ordeal every time it comes up. So I think that's important too. So kind of educating caregivers that this is normal, this is part of the disease process, and really kind of framing it as it could be considered a blessing and a curse, because they don't have to really stress out so much about their memory issue, but they don't know about their memory issue, and that can lead sometimes to safety issues and then making decisions that are not for the best. So really being open and talking to caregivers about it and kind of modeling that, I think, is an excellent point. All right, next slide, please. So I did want to talk a little bit more about educating and supporting caregivers, because again, I think this is a very important piece of what we do. And I think in the multidisciplinary memory clinic, we do a pretty good job at this in terms of making sure we're including caregivers and making sure we're taking care of them and getting them to fill out questionnaires about their well-being so that we can really make sure we're taking care of them as well. So I think kind of encouraging, like we just said, this positive redirection rather than the correcting or the power struggles. I once had a patient with AD, and her daughter, I just loved the way that she handled things. She gave an example where her mom would often, because her mom really wanted to pick out her own clothes every day, but she would often pick out clothes that were kind of dirty and soiled. And so her daughter would just look at her and say, you know, Mom, where's that blue top that you have? That one really brings out your eyes. I would love to see you in that one. And her mom would kind of light up like, oh yeah, I like that top. And she would go change. So as opposed to saying like, oh man, that shirt's really dirty, let's change that, kind of focusing on the positive. Like, I really want to see you in this shirt. It looks so good on you, and making it into this kind of positive thing. And I was like, man, I love that. She had all these good strategies. I think she worked teaching kindergarten. So she had a lot of good behavioral management strategies. So I think kind of modeling this positive redirection and talking about this positive redirection. Or another example that I read about is, because you can also see a lot of paranoia as things progress, is someone saying, hey, Uncle Joe stole my purse, and then responding with, well, it's possible he did, and I can see how that would be upsetting. Why don't we try to find it? But first, why don't we do X, Y, or Z? So kind of acknowledging the emotion, acknowledging and validating the emotion, while the things that they're saying may be factually incorrect, kind of picking up the emotion and validating how they feel. Because regardless of whether or not what they're saying is correct, they're still communicating something to you, which is often an emotion. It can be very scary or upsetting when you're losing your memory or when you're confused and you don't really know what's going on. And so they often communicate that to you in different ways. And sometimes that can present as agitation or paranoia or all of these other neuropsychiatric symptoms. So educating caregivers on focusing on and validating those emotions rather than arguing with what it is they are saying, I think can often make a big difference. Along similar lines, you often talk about avoiding re-traumatizing. Don't tell dad that mom's dead again. I've heard it described as, so continuing to remind the patient of the situation is often not particularly helpful. If they're gonna forget it a few minutes later, it just leads to continuing to re-traumatize. Also educating caregivers in terms of patients maintaining their independence to the extent that they're able to, while making sure they're staying safe. I find that that's kind of a difficult balance to focus on, where the safety versus independence, because you want people to do as much as they're able to do for as long as they can do it, in order to both optimize quality of life and keep them challenged, but you also want to make sure they're staying safe. So kind of finding that balance and talking to caregivers about those issues can be helpful and important. And then, of course, making sure that the caregivers are provided good resources and respite to avoid burnout. And I often refer people to the Alzheimer's Association in terms of making sure they have good support and access to seminars and information online that can be helpful, support groups. Because it can be difficult to be a caregiver, and a lot of them don't have a lot of resources or a lot of familial support. So making sure that you're being mindful of that. Next slide, please. So these are some other important topics that frequently come up when communicating with older adults. The first is driving. That can be a difficult one depending on the scenario in terms of whether or not people should drive. Planning for the future or a higher level of care. And in that one, you tend to run into things like, well, we promised we would never put mom in a nursing home, or she never wanted this or that. And those can be very difficult situations. I've heard some people say things like safety is more important than promises, but it's also important to keep in mind what the person wanted. So I struggle with that one. Dr. Howe, what are your thoughts on planning for the future in nursing homes and higher levels of care?
I think there's no pat answer, and that you, like with anything else, I mean, you have certain clear boundaries when, you know, safety is such a risk to the patient and or family, you make the call, but I mean, you just play it as you go, and what can people can tolerate and how well they can do without kind of judging that situation. I mean, I know for my own mother, it really came to a point when we needed more than 2 people there at a time. It wasn't just one set of eyes 24/7. And that means that somebody's always got to be there so that other person can have a break. But it was clear that we were going to build a nursing home in the apartment, that wasn't going to work anymore. You know, otherwise, if we had the resources, we had the ability to get people. And then it was just clear to me that we couldn't provide the level of care that was safe for my mother. And so that was kind of the decision. But other people have so much less tolerance that, you know, you just kind of have to go with it. Some people have just not able to do it, and that's fine.
Yeah.
And just help people kind of figure that out and not judge them about it. Everybody's different.
And making sure they're not judging themselves too harshly about it too. That's really what I see in terms of the caregivers feeling so guilty and so much stress.
If I could just do this, they, you know, you're not gonna, no.
And taking on way more than is reasonable for a person to handle because they feel like it's their duty and they would be failing them to put them into a home or whatnot. And that, I think, is a really challenging issue to deal with.
Yeah, and home is not always the best place. I mean,
Right.
people think home is always the best place, but it's not always the best place
Right.
at some point for some people.
Home can be a huge safety risk. Home can be not stimulating.
And it can be bad for the caregiver too. You have to think about their kind of long-term life, whether it's, particularly if it's an adult child who's going to live many years, hopefully past their parents, and you know, their well-being, not only emotionally, but physically, and how that shapes the rest of their life is important. Because if they trash themselves getting through this last year, and they have 30 more years of their own life, then that's not a good outcome either.
No. And often that's not an outcome that their loved one would have wanted for them.
Absolutely. Yeah.
Yeah. So that's a difficult one, I think. One of the more challenging ones. Another thing that frequently comes up are legal issues. I see so many people who are at a pretty advanced level of cognitive impairment who never really had their affairs in order, a power of attorney appointed, and it becomes so much trickier at that stage to get all of that in order than if it had been done when someone was at an earlier stage and could make their wishes known and appoint a power of attorney. So I make sure I tell everyone to get their legal affairs in order, regardless of whether they have any kind of cognitive impairment, because it's better to make your wishes known while you can.
Rather than in the middle of a crisis.
Exactly, exactly. Yeah, I can't believe how many people I see. I mean, it's not something anyone likes to think about. But it's so important. So that's definitely one that I touch on with pretty much everyone that I see. I was curious if the Alzheimer's Association has any sort of resources in helping people with this, because it does come up so much.
We do. Actually, we have an education program that I'm doing in March. And it's legal and financial planning. It's actually 2 parts. One is more the legal side. And
Excellent.
Great.
yes, I was wanting to speak and I'm like, I better not. So.
Oh no, feel free. Speak up at any time. That's excellent.
So, and we can kind of talk offline, but
Sure.
I can always get you a resource or access to that training, or we can, you know, Karen and I've spoke about maybe trying to even plan some education programs that you guys select and making them available to your patients and caregivers. But it's a very good course. It's long, but it's very good.
Oh, that's great to know about. So do people just sign up for that?
So there are several ways. You can go to alz.org/CRF, which is, oh my gosh, customer resource. Why am I not? CRF. I don't even know what it means right now. I'm sorry.
Community Resource Finder.
Gosh, yes. So, I'm sorry. My son just texted me and told me he tested positive to COVID. So I'm kind of freaking out a little bit. So you can go to alls.org/CRF and you can just enter, the city that you're in, and it will populate the recent or pending education programs that we have, and you can register right there, or you can always just call our chapter, and that number is 304-343-2717. And we'll get you registered. Or you
Teresa, will you have a flyer on it?
Yes.
Okay, so when we have the flyer, we can also send it over so you can get it out to the patients and caregivers.
Or they can always just reach out to me, and I'll get them in the right direction.
Thank you. I appreciate that. That's
Oh, no
really
problem.
helpful to know. Okay. Any other thoughts on those points? Anything to add?
This is Amy, the other Alzheimer's Association person, and I jotted down some things because it's that planning for the future part that we just, spent a lot of time talking about. But I thought, even being able to create a space for patients and caregivers to have those tough conversations together. We talk about being able to deliver a diagnosis early, and the advantage of that is so the patient can be involved in some of the planning for the future. So I think that's just really, really important. And then also, when the patient has an opportunity to be part of the care and planning for the future, I think it relieves the caregiver a little as well. It relieves that burden.
Mm-hmm.
And I would just say that part of the planning for the future is not just planning difficult things. It's how you want to spend your time.
That's right. What matters? What matters?
Because in 5 years, you're not going to be able to do some of these things cognitively. So what do you want to do now? And let's focus on what you guys want to do as a family, as a couple, to give you the best quality of life, knowing what this is in the short term. And so, you can get them to think about some of those more difficult issues. If you balance that out with, all right, so this is the time, well, not now in the pandemic, to take that trip.
Right.
But after you get your vaccine and.
Right. Yeah, I think that's a great point. Any other thoughts? All right, next slide, please. So this is kind of going off of what you just said, kind of how do you want to spend your time? So this is a quote from a neuropsychologist from that book that I mentioned, and it says, you don't need a good memory to have a good quality of life. You can live a very fulfilling day-to-day life with absolutely no memory as long as you're prepared for it, as long as you can compensate for it. There are a number of things we can do in your day-to-day activities that will minimize problems associated with not being able to remember well. So coming back to that, how do you want to spend your time? What do you want to do? Because you can still have a good life. There's a lot of doom and gloom associated with dementia and Alzheimer's diagnosis, and not to minimize how hard it is, because it's a really hard thing. But it's also possible to have this good quality of life and to still enjoy your life despite these diagnoses. So I think kind of focusing on that while also giving them the space to grieve is important.
Agree.
Any other thoughts or anything to add?
Having a cognitive disorder is a very personal thing because, the disease is affecting that thing that is your person, that is you.
Mm-hmm.
It's different than having a knee problem. And so I think you have to be able to understand that and respect that it affects people differently. But still then, once you do that, be able to help them see this.
Exactly.
That yes, this is very personal. It's changing you. You were so proud of your memory before. However, I recognize that. Let's now focus on these things that you still do well and that you can enjoy. But it is different than having a knee problem.
It is.
And I forget the power that it has over people because of that.
It's a lot of people's worst fear, I find. They talk about it being their worst fear.
It is.
My parents talk about that. Like, we're so glad you're a neuropsychologist. We're so scared we're gonna get dementia. It's people's worst fear. So keeping that in mind, but also focusing on what you can control.
Yes.
All right, next slide. I think that's it. Any questions, any other points of discussion?
Thank you so much, Dr. Keith. That was wonderful. And communication of findings is such a big topic, and you did such a great job like delving into each specific aspect. So we truly appreciate it. Jennifer, did you have a question?
Well, no, just to reiterate what you said, that was a really well done and interesting talk. And I think that there was a lot in it just that I take for communication with anybody, even not people with memory problems. I mean, it's really sort of an even more nuanced conversation about communication and health literacy too. So I just, there was a lot in there that was really interesting for me. It was interesting. I think it was when you were talking about feedback, and I'm thinking about, you know, two radically different patients who I have who have early memory loss. And one was the guy I presented today, who's just sort of sweet and doesn't engage, and he readily passes off to his wife if there are questions and stuff, and sort of says he understands everything if you ask. And then I have this other patient who, it's very interesting. And we're doing a lot by telehealth. And I wouldn't quite call her paranoid, because I think this is reasonable. She, it's to the point where her son or daughter-in-law, who there's a little friction with, have to be present when we have the call. And if she thinks that she worries that I'm going to talk to them about her without her. And I've had to explain to her, for example, in one session, I went from a telehealth visit with her to a telehealth visit with her son about him. And I had to explain, no. She said, "What are you talking to him about?" I said, "Well, it's about him. It's not about you." And it might be a little bit of paranoia, but it's also not unreasonable. She's still perfectly capable of interacting with me and making decisions about her life. And so I don't have a question, but it's just interesting that you have to, I think, be prepared for that spectrum of engagement or lack of engagement.
Absolutely. Yeah, cases present differently, and none of what you described is abnormal. Both situations are quite common, so I think being prepared to take things case by case as well is an important point.
The other thing, just quickly, is that latter patient, when you were talking about safety versus independence, she was a complicated history, but she had some surgery, so she was living with her son and daughter-in-law, and then it got to a point where she really wanted to go back to her own home, and they would let her go there for several hours a day. And then they called me because she wanted to go there overnight. And it was interesting because we didn't have a conversation beforehand, so I didn't really know what the family thought, anything. So we just talked about it, the four of us, and I just deferred to them. And I said, these are the risks of being on your own. And she said, well, I'm not going to do anything to endanger myself. But I know she wouldn't intentionally endanger herself, but as it turned out, the family was comfortable trying it. And that's what but they wanted me to kind of give a blessing. So I'm just sort of like, well, if you feel comfortable, then it's okay with me. Here are the risks, but here would be the benefit, which is maintaining independence or returning to some independence that she had lost. So anyway, I guess my question on that is that the right approach? You just have to work with the people, with the caregivers and the patient.
Yeah, I think that a collaborative approach in general is a good approach to take. I think also that trying things in a controlled environment tends to be my recommendation, where here are the risks, and if something were to go wrong, kind of what safety system do you have in place, making sure that the things that you're trying won't result in kind of any kind of catastrophic consequences. So I think trying things is great as long as it's in a controlled environment where you're prepared for the worst and it's not a situation where the person can get significantly harmed. But certainly being collaborative with the family member and the patient and making these decisions together is something that I definitely encourage.
Thanks.
Yeah, absolutely.
Can I just hop in? So we actually have it's kind of like a safety checklist for someone who, you know, is living alone and maybe is still having some questionable, you know, safety concerns. It's on, you know, I think it's alls.org/safety center. I remembered that. But it just kind of goes through and, you know, sometimes you can have that discussion with, you know, the person with the disease, like, you know, well, this is what, you know, we need to make sure that you can do, or that, you know, this is what we need to do so that your doctor feels safe. You know, I always blame it on the doctors. Sorry, guys. But it's just, you know, it's easier sometimes for you to take the blame than the family.
Yeah, I think that was clearly why they wanted telehealth with me. Like they couldn't, you know, if it was okay with me.
Right.
That's helpful. I'll keep that in mind.
I just wanted to comment that this balance you have to strike between the patient's preference and safety. I agree with you. I mean, you did a good job finessing it from what you described, but I'll just tell you quickly, I had a patient who was dwindling physically and mentally in Philadelphia where I trained. And I worked hard to get her placed in like this community living facility. And she hated it. She had been living alone for years. And within 2 weeks, she had a major stroke and ended up in a nursing home. And it occurred to me, you know, maybe what she would have rather done is been found dead in her apartment and lived out her life there. And did I do her a favor or not? And it really made me think. You know, we can't in good faith let people take risks that could hurt them, but when it's whether somebody can go home and try it or not, I think you can reasonably say, you know, they don't fail until they fail.
Mm-hmm.
And then you say, okay, it's too risky. But, you know, it's a fine line many times, but
Yeah.
it's a judgment call.
Yeah, that's very deep.
All right, thank you all so much. I hate to cut conversation short, you guys know that, but we are at 5 p.m., so I don't want to hold you all longer than we have to, but I truly appreciate the case, Jennifer, and thank you so much for that great didactic, Dr. Keith. It was really wonderful. Any resources, I know we got some links in the chat as well. I can certainly add that in the recap email. And Amy and Teresa, when you guys get more information like the flyers on the course starting in March, send that my way. I can help distribute that as well. I do have one announcement that I want to put on all of your radar. So beginning in March, so our next session, we're going to be moving our sessions from 12 to 1 p.m. instead of 4 to 5 p.m. We're hoping that'll be a little easier for more folks to hop on the calls during their lunch hours. So keep an eye out for that reminder. I'll be sending out the reminders so everyone remembers as well. So our next session will be on March 2nd, and Dr. Miller is going to finish his part 2 of the didactic on patient-centered dementia care. So keep an eye out for that reminder. Thank you all so much, and we'll see you guys next time. Bye.
Bye. Thanks.